The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hey, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. We made it to the letter E in our Alphabet Soup series that I've been going through. So today I'm going to talk about erectile dysfunction. This is a topic that comes up a lot in primary care, and we have some good options for treatment. So I hope people are not scared of this. It can be a little awkward talking about sexual issues with patients. I've thought about doing an entire podcast episode just dedicated to that. In fact, I've actually sent an invitation to Dan Savage to come be interviewed on the podcast and talk about this. He's a professional sex advice and relationship advice podcaster and columnist that's been doing it forever. Of course, he's really way too famous and huge to come on my little podcast here, but it was worth a try, right? But this is something I'm kind of interested in. I do make an effort to ask really all of my patients about sexual issues, and that's a little bit informed by my personal experience when I was younger in my 20s. My family doctor that I've seen never once asked me about any kind of sexual issue. And at that time in my life, not to get too personal about things, but my healthcare provider should have been aware of what was going on in my sexual life at that point. And she never asked, and I never really felt comfortable bringing it up with her. To be fair, I never gave her a chance. I didn't ever initiate a conversation about it, but I thought that should have been her job, you know? So I went and got the care that I needed elsewhere, but I always saw that as a big failing. So in my practice now, I try to make sure that I broach the subject somehow or another, really with pretty much every patient. At the annual physicals, I always ask about any problems with sexual function when I'm talking to males. When I'm talking to females, I usually say something in the neighborhood of like any vaginal bleeding or dryness or irritation going on, anything we need to talk about there. And of course, I'll ask about menopausal, perimenopausal kind of symptoms. But I feel like that's enough to at least let people know that the door's open if they want to talk about something. I normally will do this with new patients as well. I don't generally go into a super detailed sexual history with everybody, especially somebody I just met. I don't know that that's really necessary for most people. On the show last week, I mentioned the 5 Ps that the CDC recommends as a guideline to go over a sexual history. And for most people, I just feel like it would be kind of nosy to ask all those questions. It is important, however, to make sure you identify people who are at higher risk, like the people who should be on PrEP to prevent HIV, or people who might need counseling about STI prevention or pregnancy prevention. I really do make an effort to ask every single female of childbearing age who comes into the office if they want to be on birth control or not, which is a bit awkward sometimes, but I just think it's an important thing to ask because we're not exactly headed in the right direction with women having autonomy over their own bodies in this country right now, in my opinion. So anything I can do to prevent an unwanted pregnancy, I feel like I should do. And I think it's important just to remember that sexuality is a big part of life, really at every age. I think it's important to remember that you really can't make a judgment about someone's sexual situation just by looking at them, or just by looking at their age, or their physical health, or mental health, or whatever. I think it's just something we have to be open-minded about and ask about. And that includes very young and very old people. A lot of 90-year-olds will laugh at me when I ask them about sexual issues, but I still ask. And maybe the most uncomfortable thing is when it's a younger person. We start seeing kids at 12 years old. And as much as it makes everyone uncomfortable and squeamish to think about or say out loud, teens and preteens are sexual people. They have sexual needs. Some of them are even sexually active with other people. So I really do think it's important to ask about. And I use the same question, the same strategy with the younger people like that as I do with adults. I just say any kind of sexual issues that we need to discuss or any sexual issues we need to address, something like that. And I mean, I don't really expect a 12-year-old to say anything in response to that question, especially when their parents are sitting there with them. But I guarantee they'll remember being asked. And I just hope that lets them know that the door is open, that they can come to our office and talk about those things in the future if anything comes up, if they need to. And sometimes I will even say that, like, hey, if you have any problems in this area in the future, you're welcome to come here. because unfortunately, a lot of patients are embarrassed to talk about these kind of things. I always read about how common sexually transmitted infections are, but we don't really treat them that often in our office. So either we have a very monogamous or celibate patient population, or they go somewhere else to get that treatment because they're embarrassed to talk to somebody they know about it. And it really shouldn't be that way. There should not be any stigma. It's just another part of health and another area of medicine that we should be capable of handling in primary care, in my opinion. And I don't want people to feel weird talking about it. I generally don't feel weird talking about it, but I do notice sometimes when the patient seems uncomfortable, I pick up on that and it makes me a little uncomfortable, and then it kind of feels awkward. And like everything else, I think you just have to meet people where they are. Some people will very gladly tell you way more information than you actually need to know about their sexual situation. Some people seem just outraged that you would even ask. And then most people are kind of somewhere in the middle. So, it's a read the room kind of thing. You just have to feel what the right thing is. So as I already said, we're focusing on erectile dysfunction today. This is probably the most common sexual conversation that I have in the office just in general. It seems like a lot of women probably prefer to discuss these things with their gynecologist, which is totally fine with me. Although I will say sometimes you can't assume that a gynecologist has been talking to a patient about these sort of things. So keep that in the back of your mind. And you also can't assume that female patients are going to a gynecologist. A lot of them don't, especially on toward middle age, after menopause, or after they've had a hysterectomy. But I would say most conversations of a sexual nature really are men with erectile dysfunction. And this is something that I would say most men do not want to talk about. They don't want to acknowledge it. They don't want to think about it. I think there's a big stigma associated with this. I feel like this is somehow wrapped up in like people's idea of manhood and like you're not a real man if you can't get an erection and satisfy a woman. And from my anecdotal experience, that seems to persist well on into the sunset years of life. Sometimes even I'm surprised when men will express those concerns who I would not have even thought that was on their radar anymore just because of their physical situation, their age, whatever. And again, that goes back to not judging a book by its cover, never assuming that someone's not having sexual activity or having sexual thoughts or desires or whatever. You just can't tell unless you ask. And this is something that sometimes comes out only if you ask about it. Not every guy's going to march in the office and say, hey, I'm having a problem in this area. Sometimes it takes asking about it before they will admit to that. And even using the word admit right there, that word just has a connotation of like, this is a bad thing that you would have to admit. So let me say instead, a lot of them will acknowledge that if you ask about it, but not everyone's going to ask about it spontaneously. There's kind of a funny thing that happens where a man will call the office to make an appointment and he'll tell the ladies up front, I just need to talk to Jody or the doctor. And they just won't say why they need to come in, which I get. I'm sure they don't want to talk to just everybody about this, maybe especially not young female staff members. But I can promise you this, if you call a medical office and say that you need to come in and refuse to say what it's for, pretty much everybody assumes it's a penis issue until proven otherwise. And it's not always, but I'm going to say 70% of the time it is. So don't think you're fooling anyone. When you look at the actual physiology of everything that happens in order to produce an erection, it's pretty interesting. There are a lot of systems that have to be working and a lot of interaction between the brain and the spinal cord and the nerves and the blood vessels. I won't bore you too much with all the background hormone and neuronal information, but at the level of the organ itself, or maybe you call it an appendage, I don't know, at the level of the penis itself, I think the blood flow situation is pretty interesting to review. It's just kind of fascinating how it works, So you have blood flow increasing into the specialized erectile chambers in the penis. These are called the corpora cavernosa. There's one of those on each side, and then in the middle you have the more spongy corpus spongiosum, and then the glans penis sits on top. So the pressure in those cavernosal spaces increases as the blood flows into them, and it's actually that pressure that prevents venous outflow. So you get more blood flow to the area, and then the veins that drain the penis actually get compressed by the increased pressure. So more in, less out, and you get the erection. Levels of intrapenile nitric oxide increase and act as a neurotransmitter to facilitate the relaxation of intracavernosal trabeculae, which ensures maximal blood flow and penile engorgement. The nitric oxide acts through promoting the generation of cyclic GMP, cyclic guanosine monophosphate, and eventually detumescence happens when all that cyclic GMP is broken down, which is done by intracavernosal type 5 cyclic GMP phosphodiesterase. That'll be important later. And sympathetic pathways have something to do with that as well, specifically norepinephrine. Of course, there is a hormonal influence going on as well, and primarily we're looking at testosterone. I'm sure we all are aware that normal testosterone level is important for both libido and erections, specifically maintaining that intrapenile level of nitric oxide. As you would expect, erectile dysfunction becomes more of an issue as a person ages. There was a big survey back in the 90s called the Massachusetts Male Aging Study that showed that sexual dysfunction of some type, and that includes not only erectile dysfunction, but also diminished libido or abnormal ejaculation, usually shows up as a common problem in the 40s and increases as age increases. But it is important to remember that younger men also can experience erectile dysfunction and other forms of sexual dysfunction. So again, that goes back to, don't forget to ask. Erectile dysfunction is the most common type of male sexual dysfunction. Of the three classifications, I would say that my experience talking with patients is consistent with that. Most conversations are about erectile dysfunction, followed by decreased libido, and very rarely do we talk about ejaculatory disorders. I'm not going to talk about those specifically, but those would include premature ejaculation, delayed ejaculation, retrograde ejaculation, where the semen goes back up into the bladder, and anorgasmia, which means no orgasm at all. Things that cause erectile dysfunction or that you can think of as risk factors, anything that affects blood flow, so cardiovascular disease, hypertension, diabetes, hyperlipidemia, smoking, any kind of big surgery or trauma or radiation therapy that affects the pelvis or the retroperitoneum, neurologic issues like spinal cord injuries, brain injuries, Parkinson's, Alzheimer's, multiple sclerosis, stroke, and surgeries would be on that list as well. One of the very, very common things that we see here is erectile dysfunction after prostatectomy because those nerves are damaged when they take out the prostate. Things that affect the penis itself, so this would be like Peyronie's disease, cavernous fibrosis, or penile fracture. Ouch, kind of painful to even say that word. Hormonal problems, hypogonadism, so that would include low testosterone, hyperprolactinemia, hyper or hypothyroidism, hyper and hypocortisolism. A lot of medications can cause issues here. Antihypertensives, beta blockers are pretty well known for causing issues here. Antidepressants, very famously, tend to affect a person's ability to have an orgasm. The old no-o Lexapro is always what I remember on that. Antipsychotics, antiandrogens. Obviously, if you're blocking the effect of testosterone, then you may have issues with libido and sexual function. Recreational drugs and alcohol. And then psychogenic. I think the psychogenic is really an area that we could make a big difference in primary care. And this may be one time where it really is a good idea to kind of drill down on what is the actual problem. Like, is this a physical problem or is this a problem with anxiety? So performance anxiety, as well as some kind of traumatic past experience in this neighborhood, problems in the relationship between the partners, and then just in general, anxiety, depression, stress, all these things can have very negative effects on erections. And that's something that you can pretty well tease out, I think, when you're talking to a man about this situation, especially if this is a younger person that you wouldn't necessarily have suspected a sexual issue in. If you're thinking that might be the case, it's always good to ask about nocturnal erections. Normally about 3 or 4 times through the night, men will get an erection. This happens during REM sleep. And a lot of times he'll be aware of having an erection when he wakes up in the morning. So that's something you could ask about. Are you still getting those overnight erections? Or you can ask about masturbation. If he has no problem when he's by himself, but then there's an issue when he's with a partner, that would strongly suggest there's a psychogenic issue there. There's some thought that pelvic floor disorders may contribute to erectile dysfunction and that pelvic floor exercises may help the problem, but that's not really thought of yet as a routine recommendation for treating ED. Some other random things that can affect this: sleep disorders, restless leg syndrome has been identified as a risk factor for ED. Cycling, this is kind of a controversial area apparently, but there could be an association with erectile dysfunction and bicycling. Obviously, when you're sitting on one of those unnecessarily tiny, sadistic bicycle seats, there's a lot of pressure being put on the pudendal and cavernosal nerves, or it can actually compromise blood flow to the cavernosal artery, and those things can lead to numbness in the penis as well as erectile dysfunction of a more vascular etiology. Obviously, this is thought to be more of a problem with people who ride a lot, professional or very serious cyclists. They're also looking at the correlation between pornography and erectile dysfunction. I don't think we really have a ton of great data about this yet, but that's a whole other topic. I've heard this come up a lot in different conversations, different podcasts that I listen to about the effect of widespread access to pornography on people's sexual functions, sex lives, expectations about sex, whatever. And this is not something that I would say I've ever really spoken to any patients about. I don't think this is something I would ask about in general, unless they brought it up as a problem. But maybe that is a thing that we'll see become more of a prevalent factor in sexual issues in the future when we have more data about that. So how do we evaluate this? Just like everything else, history and physical. And you can get as detailed with this history, I guess, as you want to. I find that most of the time it's not really that necessary. Most of the time the conversation is kind of like, hey, I'm having some trouble in the sexual department. Can you help me out? And I go, oh, you want to try some Viagra or Cialis? And they're like, yeah. And that's pretty much it. But if you do have some concern that you're not really understanding what the underlying problem is, or you think that this just seems odd, like if it's in a person you wouldn't expect that in, that's probably when you venture into more specific questions and kind of trying to tease out more of what's going on with the situation. There are clinical tools to use for this. The up-to-date authors on this section are in favor of using the International Index of Erectile Function, or IIEF. There's also the Sexual Health Inventory for Men, or SHIM, or the Sexual Arousal Interest and Drive Scale, or SED. So if you want a very clinical, very validated, not super awkward tool to use for this, you could use one of those questionnaires. Maybe you could even have the patient fill it out themselves before you see them. That might be a little less awkward, I guess. My experience has been that they will definitely tell you if they suspect something like Peyronie's, which is that abnormal curvature in the penis that causes painful erections. You won't have to ask about that. They'll tell you. One thing that's helpful to think about is how rapid the onset of the erectile dysfunction was. If it happened like a lightning strike, one time it happened and then they struggled with it after that, that's definitely a psychogenic problem. There's nothing less romantic and less conducive to getting an erection than being super focused on it and super anxious about whether or not it's going to happen. Guess what? It ain't. And that can certainly overcome any kind of sexual arousal. So if it's something that just randomly started with no warning and then became a problem, it's probably psychogenic. Or obviously, unless there's some kind of big traumatic injury, surgery, something like that. We already mentioned asking about the nighttime erections. That's something that you can test for. There are devices that you can use that actually just go around the penis and measure whether or not someone gets an erection overnight. I've heard of this being done by just putting some kind of little circle of paper around the base of the penis and then seeing if the paper is broken when you wake up in the morning. I guess that would be a very cost-effective option for doing a little bit of testing there. Obviously, you'd want to be careful not to put something that's so tight around there that it's not going to expand. You can also have a problem where the person can get an erection, but then they have trouble maintaining it. They call that non-sustained erection with detumescence after penetration. And that's usually due to either anxiety or venous leak. So the blood is leaking back out through those veins when they should be compressed. I said earlier that sympathetic stimulation, particularly through norepinephrine, affects the whole process of losing an erection. And so if you have anxiety that's making you worry about this, that adrenergic hormone release is physically going to make it more difficult to sustain erection. So that's a rock and a hard place situation there, or I guess rock and a soft place. Obviously, if there's conflict within the relationship that's contributing to this, that's probably going to be out of our wheelhouse, but you might recommend some counseling therapy for that. And counseling can be helpful just for the individual to go to as well to talk about this, particularly if you think it is a primarily psychogenic issue. You can also talk to their partners about it. I would definitely let the patient drive that. If they're bringing up the issue in front of their partner, I might not have a problem with that. I don't know that I would call the patient's partner on the phone after seeing them and ask what they think about it. I'm pretty sure I would keep that confidential unless the patient wanted to bring their partner in. As far as physical exams, I'm generally not doing any kind of genital exam when we're just talking about garden variety erectile dysfunction. I don't typically do that unless there's some physical problem that they're reporting, right? Like, hey, my testicle hurts, or there's this big bulge in my scrotum, or something like that I really should look at to accurately describe. Maybe that's a cop-out on my part, but in most situations, I don't know that there's really much we're going to see or feel that's going to add anything to the discussion. But you can definitely assess the pulses in the leg, the femoral pulses and the distal pulses lower, so the popliteal, dorsalis pedis, posterior tibialis can give you a clue about circulation to the lower part of the body, right? The arterial circulation for the genitals comes off of that system. So if you can't find femoral pulses, or if you would like to auscultate, you can listen for bruits in the femoral arteries, and that might give you an idea that there's a significant occlusion of blood flow to the area. You can search for penile plaques indicative of Peyronie's disease. I'm not going to be doing that. I will leave that to your imagination to decide how you might do that. Not me. That would be a urology thing, I think. One thing that might be kind of useful is looking for normal or abnormal hair growth patterns or gynecomastia or small testes that might indicate a hormonal situation that's going on. There's that cremasteric reflex you can evaluate. The cremaster muscle surrounds the spermatic cord and testes, and so it helps regulate the temperature of the testes by raising or lowering the testicle. And in order to check that reflex, I'm just going to read this from the UpToDate article. You stroke the inner thighs and observe ipsilateral contraction of the scrotum. A normal response is cremasteric contraction with elevation of the testes. Yeah, I'm not going to be doing that either. That reminds me of something I was going to mention but forgot about. It's important for us to acknowledge the awkwardness of this whole situation from the patient's point of view. It's not so awkward for me. The whole thing is just a body and we're just talking about a problem that I'm trying to solve. And it doesn't really strike me as all that awkward, but when I know the patient's uncomfortable, it kind of makes me uncomfortable. And I think we just have to, in these situations, when we're talking about anything involving genital exams or examining sensitive areas, we just always have to be cognizant of what a big deal that is for the patient. Of course, we always think about this with different genders, right? Like, it's not even a question if I'm doing a breast exam or any kind of genital exam on a female patient, there's going to be a nurse in the room with us. I do try to offer that to men as well. I will actually say, do you want me to go get one of the nurses to come in here with us before we do this? So far, I've not had anyone take me up on that. My experience has been that males are very much like, no, please, nobody else in here. This is bad enough. But don't forget to offer it. And in my personal situation, I don't know how many of my patients really know that I'm gay, but maybe that would affect their thinking in that regard. So just remember it's an awkward thing and just do whatever you can to make it less awkward for the patient. Obviously, you want to look for any of those risk factors that we talked about. So clearly, if they have out of control cardiovascular disease of any type, diabetes, hypertension, blah, 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 we need to be checking for all that stuff and treating those underlying issues. I'm checking a lot more testosterone now, I think. It's more of a popular thing that people will come in asking to have their testosterone level checked. But once in a while, it'll kind of come up naturally in conversation. And when you start hearing about low libido and erectile dysfunction, that sort of thing, it's not a bad idea to offer to check their testosterone level just to see. Another thing you can do is actually use ultrasound to evaluate the blood flow to the penis, just like you can look at blood flow in any other arteries. The ultrasound imaging would be a urology thing. I would say if you're not an expert in that, you don't want to be trying to ultrasound somebody's penis. If you're a POCUS person, I don't know that I would go after that just in the office right there. There is this evaluation method called cavernosometry, where you actually stick a needle into each corpora cavernosa. One of those needles is attached to a transducer to measure pressure, and the other has a saline infusion running into it. So you see how much saline it takes to achieve and maintain an erection, and that can be measured. Good luck getting anybody to sign up for that. I don't know that I've ever heard of a urologist in our area doing that, but it's out there. Apparently, penile ultrasound has pretty much completely replaced that cavernosometry because you get pretty much the same information, and obviously it doesn't involve sticking a needle in someone's penis, so it makes sense that would become the more preferred modality there. They can also do penile revascularization surgery, just like you can do revascularization of hearts and legs and other things. That can happen in the penis as well. So that would be a reason to look specifically at the blood flow. So what do we do about this situation? Typically, we're going to start by using medications. And again, this is assuming we've already addressed all the other potential disease processes that could be affecting this. But typically, we are going to use medications, and typically that's going to be the oral phosphodiesterase 5 inhibitors. Remember that whole phosphodiesterase thing I said would be important earlier. The medicines like tadalafil, sildenafil, which are brand names Cialis and Viagra, inhibit that PDE5 enzyme that breaks down the cyclic GMP. The other two that are available are called vardenafil, which is brand name Levitra or Staxin, and avanafil, brand name Stendra. There are some differences in those. The sildenafil and vardenafil are pretty much interchangeable as far as their onset time, duration, that sort of thing. Tadalafil has a much longer duration of action than either of those two, and avanafil starts working a lot faster than those two. I don't know that I've ever used vardenafil or avanafil for a patient. I typically stick with either sildenafil or tadalafil. I will say that most people seem to like the tadalafil better. I think because of that longer duration of action, it gives you more flexibility I would go out on a limb and say that most people are not really interested in going, hey, are we going to have sex in 30 minutes to an hour? Okay, I'm going to take my sildenafil now. Because that's really what you should do with the sildenafil or the vardenafil. It'll take them about an hour before a sexual encounter. It should be taken on an empty stomach, and it's going to last about 4 hours. Tadalafil, if you're taking it just as needed for erectile dysfunction. And by the way, I really hope that when they were coming up with the name of this, that somebody thought, hey, how about Tadalafil? I hope that's the case. With tadalafil, you also have the option of dosing it daily. So they do typically a 5 milligram dose every day. This seems to be about as helpful after a while as taking a single dose of 20 milligrams. This is also helpful for urinary flow in patients with BPH. So you can actually use it as a treatment for BPH too. So sometimes you'll kind of get a double benefit there. With that Avanafil, you can take the 50 milligram dose 30 minutes before sexual activity. With the 100 or 200 milligram doses, you can take that 15 minutes before. So a lot quicker onset of action there. Side effects and precautions. I think everyone in the world knows that you shouldn't take a PDE5 inhibitor and a nitrate at the same time because of severe hypotension. You got to watch out for hypotension also if you are giving these along with an alpha blocker. And obviously, a lot of patients with BPH are already going to be on an alpha blocker, so got to be careful there. And I've definitely seen that a time or two in my own practice. Side effects, typically things that you would think of related to vasodilation. So headache is probably the big one that I've seen in practice. Nosebleed, rhinitis, diarrhea, heartburn are all possible. There's this thing with sildenafil where it can cause blue vision. Sildenafil is a PDE5 inhibitor. There's a PDE6 inhibitor in your eye, in the retina, that plays a role in color vision, and that those two can kind of get crossed up. So you can get this situation where your vision looks blue for 2 or 3 hours after the medicine starts working, and then it resolves spontaneously. I'm going to say I didn't know that, so if anyone ever reports that, it wasn't their imagination, it's for real. They have not seen that with the other PDE5 inhibitors, by the way, just the sildenafil. There can be some more serious eye issues, including a thing called non-arteritic anterior ischemic optic neuropathy, or NION. Sounds kind of scary. Other things include retinal detachment and retinal vein occlusion. We don't know how this affects people who already have retinitis pigmentosa. They recommend caution in these patients, but it seems like it hasn't really been studied in that population. There have been rare reports of sudden hearing loss with these medications. And of course, the big thing I guess that everybody's aware of from the commercial is the potential for priapism. So they say on the commercials, if you have an erection lasting longer than 4 hours, you have to go to the emergency room. Obviously, if blood stays in the penis for too long, it can get clotted and cause a lot of permanent damage. So it is important to review that with your patients when you're prescribing these. The definition of priapism is an erection longer than 4 to 6 hours. So I guess we're erring on the side of caution there with the 4-hour advice. Obviously, they need to get that blood out of there, and that can usually be done, I believe, just with a needle and aspiration with a syringe, as well as alpha adrenergic drugs. In one of the Curbsiders episodes about this, the urologist that was talking about this was saying that she always tells men to take Sudafed if they do get a priapism, because that adrenergic stimulation will help relieve the problem. I think she was saying she would actually even write them a prescription for Sudafed or pseudoephedrine to use as needed for priapism, but I tend to just tell people, like, hey, if this was to be a problem, you could try taking Sudafed and see if that fixes it. Apparently, most priapisms that lasted 36 hours or less could be successfully treated by those two things, draining it or using alpha adrenergic drugs. After 48 hours, they generally had to put in some kind of shunt surgically to relieve the problem. And if that doesn't fix the situation, then after that, they pretty much just think about putting in a prosthesis, because it's probably not going to work anymore after that. If you have a priapism lasting longer than 36 hours, it does not respond to putting in a shunt. And that's a glandulocavernosal shunt, by the way, if you're interested. So that's normally what we do in primary care, or in my office at least. I would say don't be scared to write these drugs. They put these warnings on the commercials that say, make sure and ask your doctor if your heart is healthy enough for sexual activity. And I don't know that I've ever really seen a patient that I was scared to tell that they could have sex. I mean, to me, this is like a self-limiting problem, right? Like, if you can't breathe or move or function because your heart's not pumping well enough, certainly you're not going to be up swinging from the chandeliers, right? There also seems to be this misconception that these medications raise your blood pressure, when in fact, because we know they are vasodilators and the risk with them is hypotension. They tend to lower blood pressure, or at least if they're going to affect your blood pressure, it would tend to be lowering it. So pretty commonly men will ask, am I going to have a stroke when I take this? Is it going to make my blood pressure go up? And it's like, no, it shouldn't. Obviously, sexual activity can be taxing for the heart. Obviously, you're getting some sympathetic stimulation there at one point or another. We all know stories of people who have heart attacks and die during intercourse or right after intercourse. There's not been an association with these medications to date, so honestly, I'm not really scared of prescribing them. About the only time I'll balk is if somebody is already on a nitrate. If they take the isosorbide or one of those long-acting nitrates, that's going to be a deal breaker. And occasionally, of course, you do still have people that are carrying nitroglycerin tabs around in their pockets, so I'm a little bit leery of doing that. I normally just write on the prescription. I'll tell the patient and also write on the prescription, like, do not take this with nitroglycerin. Another misconception about these medications that's out there is that you're going to take a pill and immediately get an erection. It's good to let the patients know that it just makes it work like it's supposed to. You still have to have some sexual arousal to cause that process to occur. So pretty commonly men will want to be reassured that they're not going to immediately get an erection if they take this. For a while, the cost of these medications was an issue, but now at least the tadalafil and sildenafil are both generic. There still are some people that think they can't afford these medicines, but that should not be the case. I have noticed that until recently, CVS and Walgreens seemed like they were still trying to charge a lot of money for these compared to other pharmacies. But I'm looking on GoodRx right now, and it seems like everything that comes up is pretty reasonable. I'm looking at 20 milligram tadalafil or Cialis tablets, and it looks like everything is like $20 or less for 30 tablets. Same with sildenafil. I'm looking at 30 of the 100 milligram tablets, and they're all $20 or less. I don't know about insurance coverage. A lot of people also have this misconception that if their insurance won't cover it, that means they can't get it. But for whatever reason, a lot of these pharmacies will not tell you the cash price of the medicine unless you ask for it. So this is a medication you can very confidently instruct your patient, hey, if your insurance won't cover it, just ask for the cash price. It should be super cheap. You can just buy it. These are also available mail order from the Cost Plus pharmacy where they're super cheap and you don't have to use insurance at all. So yeah, there should be no cost barrier for getting these medicines anymore, at least the ones that I commonly use, the sildenafil and tadalafil. If the medications don't work, and sometimes they don't, particularly in people who have underlying vascular disease, people that you would look at and go, yeah, I'm not surprised that you have a blood flow issue, and I'm not surprised that these medications are not helping so much. There are still other options. The least invasive would be vacuum therapy. There are all kinds of vacuum therapy devices, aka penis pumps, out there, which are exactly what they sound like. If you're not familiar, the penis goes into the cylinder and you use some kind of mechanism to generate negative pressure to literally pull the blood into the penis. A lot of times those are used in conjunction with constrictive bands, aka cock rings. My impression of how that works is you put the constrictive band around the pump itself, you do the pumping, and once the erection is achieved, then you slide the band off of the pump and onto the base of the penis. I believe most of those are intended to go around the penis and the scrotum, so it kind of constricts the very base closest to the pelvis. More invasive medication options are intraurethral alprostadil. This is essentially a suppository that the patient sticks into the urethra, through the meatus at the tip of the penis. Then they massage the penis for up to 1 minute to make sure that the medicine gets distributed evenly inside there. I've tried this maybe once or twice and it has not gone very well. And you kind of understand why, I think. It also commonly causes both penile pain and bleeding. Of course, we know the urethral tissue is very vascular, so it's not hard to imagine that they could see some bleeding if they're trying to jam this medication in there. And a lot of times, apparently, there's a cost issue with this too. So I don't see this done really ever by urology, at least not in our area. The other medication option is penile self-injection with alprostadil, which is prostaglandin E1 and or papaverin. I guess in the US, it's the prostaglandin E1 that's the only FDA-approved drug for this. There are other medicines that are used in other countries. That's according to UpToDate, but I know locally most of our men get these medicines compounded from a compounding pharmacy, and as far as I know, they're all on one called Trimix, which is a mix of alprostadil, papaverin, and phentolamine, all with the goal of increasing the blood flow into the penis. Men absolutely look at me like I'm crazy when I suggest this, but I have a handful of patients that do this, and all of them absolutely love it. They say that once you get past the psychological hurdle of sticking a needle into your penis. The medicine actually works really well, and they say the injection doesn't hurt at all. Like, everyone I have that does this is very happy with it. So this is definitely a viable option. I will not hesitate to recommend this to men who've tried the oral medication and it hasn't worked. Obviously, that's a urology thing. I guess you could do that in primary care if you were comfortable with that. I don't know, but I'm sending them to urology to talk about doing this for sure. One of my patients always makes a joke about injecting different amounts of this stuff. He'll say something like, yeah, I can either inject a little bit if we're just having a normal time, or I can inject a lot and we call the neighbors. I don't know if he's kidding. Maybe not. I don't know, but it's very funny. And I guess that's another thing to point out about talking to patients about this stuff. Like, it's okay to acknowledge the awkwardness. It's okay that it's funny. Like, it is kind of funny sometimes talking about this stuff. I would encourage you to, like, be a human being. You know, it's okay if you drop the clinical mask and just kind of roll with the punches if somebody's clearly comfortable or clearly laughing about something like this. Like, it's okay. The most invasive treatment option is going to be a penile implant. So this is where they pretty much scoop out all the cavernosal tissue and replace it with a device that produces the erection. I don't know if I mentioned this when I was talking about going through gross anatomy, but my cadaver in gross anatomy actually had one of these things. We did not know that. So there's a very interesting moment where somebody else who did not destroy all the structures we were trying to look at was doing the dissecting and kept running into this very hard tube, like in the suprapubic area. And finally they called the instructor over and was like, "What's this?" The instructor got very excited and was like, "Oh, I know what this is. We've seen it before." He runs, I don't think I'm really exaggerating this. He runs into the back room of the lab and emerges with a plastic tub, which is originally intended to hold bubble gum. You know, it had the whatever super bubble or super pop. It's a bubble gum bucket. He takes the top off and he reaches it and he pulls out this gigantic penis with all this device attached to it. They had found one of these in the past and saved it. So anyway, I do have some experience actually figuring out how one of these things works. I'll leave it at that. There's a reservoir of saline that you use to inflate the implant, and there's a little valve that hangs down in the scrotum, kind of between the testes. So the patient activates it by squeezing that little valve. You kind of pump it up just like remember those tennis shoes, the air tennis shoes where it had the little round thing on the tongue that you would squeeze repetitively to increase the pressure inside the shoe? It's that kind of thing. You just pump it up. And then when you're ready to deflate, there's another part of that little valve that you just hold, and it allows the saline to escape and go back into the reservoir. And that reservoir is implanted, the one I saw was kind of under the skin of the lower abdomen or the suprapubic region. And again, that's another thing that sounds crazy and barbaric when you tell somebody about it, but the patients I have that have them, and I know of one or two that we have, seem to really like it. It would obviously take all of the doubt or psychological pressure out of the situation because you know it's going to work. So really not a bad option if you have somebody that's motivated to do it, I would say. There are some experimental therapies, including stem cells, low-intensity shock therapy, and yes, that is directly into the penis, shock therapy of the penis. The stem cells also injected into the intracavernous tissue. There's hyperbaric oxygen therapy, platelet-rich plasma. I'm not sure how that's delivered. Things that we know are not effective or are no longer used for this include melanocortin receptor agonists, which are currently not approved or commercially available, and apomorphine. That was an approved product for ED in some countries, but evidently it was totally discontinued because it didn't work. If you've identified a hormone issue, a testosterone deficiency specifically, of course you can treat that. I'm not going to talk about that now on this episode, but it's pretty straightforward, supplementing testosterone and seeing if that helps. As far as the psychogenic erectile dysfunction, obviously counseling is a good thing to recommend. You can use medication to treat the anxiety, but of course those medications can have a negative effect on sexual function directly, so that's kind of a risk-benefit situation there that you have to think about. I will say I have found that sometimes just having a bottle of medication available will help a lot with the anxiety component of this. We do have patients that don't actually have to take the sildenafil or tadalafil in order for it to be effective, but just knowing that they have the option of taking it, that it's right there in the drawer if they need it, is kind of all they need just to reassure them and help them relax and get over the psychological aspect of the problem. So sometimes just writing the prescription can be helpful even if they're not actually taking it. So yeah, I think that's about all I have to say about the topic. If there's anything I left out, if you have anything you want to contribute, please, of course, get in touch. Special thanks to our Patreon supporters. Thanks to all of you for listening. Have a great week, and I will talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients, in that order.